So just to let everybody know, this is being recorded, as well the slides are going to be sent out along with the recording, okay? So today we're going to be talking about foundational community supports, more specifically finishing up and tying up this end of the golden thread, focusing on service delivery and then documentation of services. Okay, just need to find my chat box, which I have found. So just to give everybody an idea of some general information, I would suggest everybody either, if you need to, call in for sound. Thank you, Zakia. Zakia just added that into the chat box. So if you don't have audio up, you can type in the phone number, the 3014 number, and then the meeting ID number, and you'll be able to get sound in. Right now, everybody is muted. You can have your video on, or you can choose to have your video off. If you do choose to have your video on, I just ask that people be respectful of your background and of what's going on in the video. Only because we've had some feedback from participants. We've been doing these sessions in meeting form, so we don't have the ability to be able to turn off people's videos. Everybody has their own ability to do that. So we just ask for everybody to just be mindful of that. The last thing I want to mention is if you are typing things into the chat box, which you're going to have to if you want to answer some of the questions I have, you want to make sure that you change the response to everyone, or all panelists and all attendees. And that's just so that everybody is able to view what you're saying. And then once again, this presentation is being recorded, okay? All right, so this is actually the last training in the series. For those of you who have been present for all, we did the first training, which was on the golden thread and the assessment process. We had our middle training our first training, my colleague Shelly presented, and she's on this call right now, also providing support. Last week, Zakia, who's also on the call, presented on the individualized service plan components and goal development. And then today, like I said, we're going to talk about the individualized service plan services and documentation, okay? So yeah. Let's get it started. Before I do that, though, I do want to thank everybody for being on. I think Zakia, Shelley, and I had a lot of fun doing these webinars. We always like presenting and doing trainings for all of you out there in Washington. If anybody was wondering, I know we got some questions about this on the other webinar that Shelley and I are doing. We don't know if we're going to do this again. We could potentially do this again as a training if Washington State asks us to. So if you did find this information helpful, if you found that it could potentially be helpful for other colleagues of yours that weren't able to attend the training, please reach out to Washington and let them know, or even put it in our evaluation if you found the information to be helpful, okay? Just give you a little information about myself. My name is Emily Bands, like I said. I've been a lecturer in the Department of Psych Rehab and Counseling Professions here at Rutgers since April of 2019. Some of you may know me. Like I said, I've been doing the Golden Thread webinars on Tuesdays with my colleague Shelly. I've also participated in various learning communities, including the one yesterday, the Landlord Outreach Learning Communities. I've done webinars for those. And then I also did an in-person training out in Washington last September. But here in the department, my main role is to work on our training and technical assistance project, which is geared towards the behavioral health providers here in New Jersey that provide Medicaid fee-for-service services. Before I came to this department, I actually worked in supportive housing in New Jersey. I started out as a case manager, and then I worked my way all the way up to a program manager. So all the services that you provide, or some of the services that you provide, I've done similar work. So I kind of know what you all are working with, and in terms of supervision and being a supervisor, I also have experience with that as well. Okay, so that's just a little bit about me. So we're gonna get it started, get it rolling here. Last week, Zakia did give you all a learning application. So the first piece of the learning application was to introduce your staff to the KSR form. And if you did introduce your staff to this KSR form, or if you used the KSR form yourself, if anybody wants to share, what did you learn from using it, or what did your staff learn from using this KSR form? Additionally, and if I understand if nobody out there was able to use the KSR form or got their staff to use it, or if you weren't even at the training last week, does anybody have any questions about the KSR form? I think Zakia did a pretty good job of explaining it last week. Her and I did a role play. But does anybody have any questions or concerns about that? Just take a minute, think about it. Oh, Shelly put the form in the chat box. An off-topic question, how's the weather out there in Washington today? Because over here on the East Coast, it is raining, it is dark, it is dreary, and I have no energy today. So I'm just kind of wondering if everybody is feeling or experiencing the same thing, because I feel like you all are pretty, well, if it's sunny and beautiful, what's happening here, people? I feel like everybody's usually in the chat box and typing away. I guess I'm not just not asking you guys good enough questions. So we'll move on from the KSR. I'm happy you all are at least experiencing beautiful weather. Like I said, it's super, super dreary here today. So I'm happy that you all are going to have nice weather. Oh my gosh. Sunday to Tuesday, the 100s. Ugh, I'm not looking forward to that. Sorry about that, Bill. All right. Well, that's good. I'm happy you guys are at least experiencing good weather out there. All right. So switching gears a little bit. Did anybody have the opportunity to try to use, oh, I'm sorry, Elke. I'm sorry you didn't receive the follow-up from last week. Usually at the end of the training, there's been a learning application, so you might have hopped off before Zakia presented it. That's okay. But one of the other learning applications from last week was to try using a new supervision strategy. Either that be the collaborative agenda that Zakia shared with everybody last week. Zakia also talked about a ride-along observation and providing just praise. More specifically, Zakia said last week that something she would do was send out an email like quarterly out to more of the administrative staff at the agency to let them know what her staff were doing, to provide some praise and positive feedback. Did anybody have the opportunity to try a new strategy, and was there any good outcomes, or did you guys get any feedback from your staff? All right. Well, everybody, if you did get to do it and you want to share, wonderful, put it in the chat box. If not, that's totally okay. We'll keep it moving though. I will say though that throughout this presentation, I am asking a lot of questions, only because a lot of the information that I'm presenting, I'm sure is information you already know, since I'm assuming most of you are supervisors. And we'll get to sort of figuring that out when I do this poll. So just to make sure I'm clear here, I'm just launching a poll here. So just to get an idea of who is out there, who's direct care staff, who's a clinician or registered nurse, supervisor, other. I am seeing some people answer, thank you very much. So I am seeing some supervisors out there, which is great because this training is really geared towards supervisors. So just as a warning, I have a lot of questions for you, for those of you out there that are in supervisor roles, okay? Bill, thank you. I guess you're a utilization review coordinator, and with compliance, this training also applies to you as well. We have someone out there who's a clinician or a registered nurse. So Bill let us know what his role is. And Amity, I'm assuming you're a compliance officer. You're one of the other individuals who answered other. All right, awesome. So this is great because this training, like I said, is going to have a piece of it focused on documentation in regards to the progress note. And the last piece of the training, we're going to talk a little bit about utilization review, compliance, and sort of how to audit charts. And I have some questions and some resources that I'm going to share with everybody, but I also wanted to give individuals the opportunity to sort of share information with each other. I know you all do very different things at each individual agency or organization, but just from being on the learning communities and from being on the other trainings that I've done, being able to communicate with each other and give each other hints, tips, suggestions, I feel like is always very helpful, okay? So I'm going to end the poll. Thank you all for answering. It does seem like we have a good amount of supervisors on here, which is great because in general, this training is for you. All right, so today's focus is going to be on defining and looking at intentional service delivery and recognizing how to provide intentional services. We're going to discuss how to document consumer progress, and then we're going to apply the components of the DAP format to a progress note, okay? So here we have our general golden thread. This is something that Zakiya and Shelly and I have been sharing with you all throughout these 3 sessions. And the piece of this that we're going to focus on right now is going to be providing intentional services, right? So we've already done the engagement piece with the individual. We've already looked at assessing medical necessity and doing the assessment. Part of the assessment is looking at strengths and needs and helping the individual to determine what they are. From that assessment, from looking at strengths and needs, you're helping the person to identify personal goals. And then those personal goals then become what is developed on the individualized service plan, right? And from this individualized service plan, that's how staff are then able to go out and provide intentional services. Does anybody have, just in general, have any questions about the golden thread? I'm gonna assume a no, but if you do have any questions about the golden thread, let me know, okay? All right, so intentional service delivery, okay? Has anyone heard of this term before, intentional services? Has anybody out there ever heard that term before? And if you have, what do you know about intentional services or intentional service delivery? Thank you, Amity. Planned interventions with a purpose. Patricia, going into a meeting with someone knowing what you've planned. I'm seeing a lot of planned here. Thank you, Patricia. Anybody else have anything they want to share in terms of what intentional services are? Where Amity and Patricia, you guys are hitting the nail right on the head, by the way. Having a plan for what services will be, absolutely, Angela. So yeah, so a plan, right? So intentional services are, oh, and Stacey, services that support real progress. I like that, right? Because when you're providing intentional services and you are going off of the ISP, like we saw on the golden thread, there should be real progress there, right? Because we already know that that's something that the person wants to work on because we're working on their goals with them and whatever objective and interventions are on the plan. So I like the way that you worded that also, Stacey. So intentional services are supposed to be purposeful, deliberate, and planned, right? So there's some thought that should go into you determining what intervention you're going to work on with the person and what information you're going to bring to the table to work on that intervention. Because you can write a really great service plan. It can be specific, it can be measurable, it could be timely, it could be attainable and relevant to the person. And you can write really specific interventions, but there's a lot that you can do with interventions sometimes, right? Because interventions, although they're specific, there still is a little bit of leeway, right? So it might be focusing on using motivational interviewing skills you know, to help the person to obtain a resource or something like that. But that doesn't mean that you can't do a little research beforehand and, you know, find a worksheet to use, or, you know, find a workbook that might be might be helpful to the person and provide that to them, right? So there are some steps that staff can take and that you can encourage your staff to take in order to provide intentional services, right? And in turn, intentional services are important, right? So intentional service delivery really focuses on the services that are delivered on the ISP, right? But see, I'm always jumping ahead here. I did this the other day too, right? And intentional services also talk about and look at planning what services are going to be provided during the visit. However, services other than those identified in the ISP can be provided, like crisis intervention. And just so you all know, we talked about this in the webinar on Tuesday also. And a lot of the direct care staff on the webinar, I'm not sure if you all out there have any staff on the webinar, but there was a really good conversation around, what if the service isn't on the plan? What do we do then? And absolutely, if a service is not on a plan, it can still be provided. However, oh no, I stopped my screen sharing, everybody. I'm so sorry. I hit the wrong button. Okay, so services are not on the plan, okay? And you're providing them to the individual, and it's something that is happening over and over again, you definitely want to modify the ISP, okay? So just to kind of summarize, intentional service delivery are services that are planned, okay? It's something that should be planned out before you go out and meet with the person, but sometimes stuff does happen, right? I'm sure everybody out there, all you supervisors out there, how many times do you get a call from a staff person who went out to meet with somebody and they're calling you because somebody's in crisis? Does that happen often? I'm going to assume it does. Yes, right? I used to get calls all the time where I would, the staff would leave for the day and they'd be looking forward to the outreach, and they provided this, they had all these resources, they had worksheets, they had a great plan, and they got there and they were calling me and they're like, Emily, this person's in a crisis. I think they need to go to the hospital. Or they're calling me because someone's electricity was turned off, or they're calling me because somebody has no food. Crises always happen, right? But this idea of intentional services should always be followed, because even if something does come up that is like a crisis, if it's something that is going to take a couple of outreaches to resolve, or it has to do with teaching somebody a skill, whether that be budgeting because they lost their electricity or they have no food, the plan should absolutely be modified in order to adjust for that, okay? And that kind of helps with keeping in line with intentional services. Okay. So here are some benefits of intentional services, right? The more intentional services you have, the more the plan is going to drive service provision, and the more that services will have a specific and intended outcome, right? So you're working hard to create this ISP for a reason, right? You're working with the individual, they have a goal they want to achieve, you know, this is the step they need to take, which is the objective. You know that these specific interventions are going to help them achieve that objective, which will then help them achieve this goal. So there are some specific intended outcomes, right? When you're not providing intentional services, or if you do continue to provide intentional services, there's going to be less of this idea of following up with somebody or checking up on somebody. What was service provision like out in Washington before you guys started providing foundational community supports, before this idea of like Medicaid fee-for-service? Was there a lot of following up with and checking up on people? Or were services still being provided, that intentional services were being provided, you guys were providing services off of the ISP? What was happening? And I only ask this, and please feel free to answer in the chat box, but I only ask this because when I was working out in New Jersey here, providing supportive housing services, okay, I see some answers. So working out here in New Jersey, though, we weren't providing intentional services, or my agency, at least, the agency I was working with was not really providing intentional services. I would say, like Amity, there was a mix of both. But your agency is a little different, Amity, it looks like, because you guys do employment. Oh, I like that, Patricia. More reactive services than proactive services, right? So a lot of putting fires out and getting that sense, right? Somebody's in crisis, somebody needs something, and now you have to go out and solve a problem or fix something, right? And that was actually happening a lot at the agency I worked at too, right? Sometimes we would work off of the ISP, but definitely, the services were more because we were reacting to a specific problem. And that's hard because it gets individuals out of this habit of, or not even a habit, but out of this framework of staff are here to help me with something. And this is the specific thing that they're here to help me with. Because I always felt like when I was working with individuals, it was really hard for me to go out and meet with them and actually work on the plan, because they were so used to, calling and needing a ride someplace and me having to go out there and, provide transportation to them. They were more used to me going out there and just kind of saying, hey, I just wanted to check up on this. And then it's sort of ballooning into something else and snowballing into something else, right? So it creates some challenges when you're trying to provide, or have a really good working relationship with somebody, because then you're unable to sort of be consistent in your service delivery, right? And it was hard for my supervisor because she didn't really have any good tips or help for me in order to be able to continue to provide intentional services to people. So it was challenging. Sarah, you said that staff would write goal plans with vague services and interventions, and we would rarely see the participant again. Wow, and that's kind of a shame, right? Because you're there, you want to help somebody, right? Your goal is to help the person and try to help them achieve whatever goal they're working on, but it sounds like maybe things were so vague that the person didn't really know what was happening, and maybe that's why they didn't come back. So that's a shame. I'm sorry to hear that, Sarah. So Medicaid fee for service, any services that are within that umbrella, and they're going to be intentional, right? You have the Medicaid fee for service programs are a lot more structured, which is really a good thing, because now you have a specific way of doing things, and the individual you're working with knows that that's how you're going to be providing services, that they are going to be through this framework and through this structure. And it's going to be easier, hopefully easier, for your staff to go out and help them achieve their goals. And that's when you're going to see these specific intended outcomes happening, right? So intentional services do have some benefits, okay? So let's take a look at some purposeful visits, right? So we have this statement of going to check in on Bob, okay? How could you encourage staff to reframe this visit, right? So Bob is used to staff coming out and going to check in on him, right? So how can you reframe this visit with Bob? What can we do to reframe this? So think of any goal, Patricia, right? Any goal or objective you might be working on with one of your own consumers that you're working with. Instead of going to check in on them, what might you say? So Amity said, so instead of saying going to check in on Bob, going to see if Bob is meeting his employer's expectations in regards to stocking the dairy section within the expected time frame. That's a great specific example. I really like that. And then we also have, okay, so we have Megan. We have Megan who said, I am meeting with Bob to work on, we'll say, completing a specific apartment application. Awesome. I like that one. And I spelled apartment wrong. I apologize for that. What else do we have? Right. That's okay, Lindsay. Right. So you want to be specific, right? You want to be goal oriented. And I like these two examples because one is very employment related and the other is very much housing related, right? So you're looking at meeting with Bob to ensure that he's meeting his employer's expectations around his job duty, right? Or what, we'll talk to Bob about his ambivalence towards going to his mental health appointments. Absolutely, right? So when you go and meet with Bob, you don't want to just say, hey, Bob, I'm here to check in, right? You want to be very honest and say, hey, Bob, I'm here to talk about this. I don't know if you want to use the word ambivalence, but talking with Bob about, so you can even just say, hey, Bob, I'm here to talk about your mental health appointments. The last time we spoke, it seemed like you were unsure about whether or not you wanted to go, right? So just being very specific about what you're doing with them so that everybody is clear about what your role is as a staff person, right? It's awesome. I like these examples. They were really good. All right, let's do another one. So if we look at Mary, okay? So here we have, hey, I like that, Patricia. Hey, Bob, I noticed you missed your last appointment with your counselor. What happened? Perfect, that sounds great. All right, so if we look at Mary, okay, we have this idea of dropping off Mary's meds. So what would we do instead of just dropping off medications for her? And I'm not sure if this is something that any of you used to do before FCS out in Washington, but something that was like a regular service some agencies would provide to individuals. They would go to the pharmacy for them and pick up their medications and drop them off for them, which in New Jersey, excuse me, it's not something that we can do anymore out here. Or at least do and get paid for. I like that, Patricia. Check in with Mary to see how many refills she has on her medications and see if she has an appointment to see her medication provider. If not, schedule the Okay, we have another one from Megan. I'm taking Mary her prescription as she runs out of medications today and she lost her bus pass. We will then problem solve solutions for transportation and time management so she can pick up her medications next time. I really like that, Megan, right? Because again, sometimes these crises happen, right? Sometimes a crisis happens, so sometimes you have to pick up Mary's prescription, right? So I'm going to pick up Mary's prescription, but I am going to problem solve solutions for transportation and time management since she lost her bus pass and will need to get her meds on her own next time, right? Does anybody else have any other suggestions for how to reframe these visits? I like that, Megan. I like that you had this example where you're taking Mary to, you're going to actually get the meds for Mary, right? But instead of just getting them for her and just leaving it at that, you're going to do some skills training, right? You're going to focus on time management, and then you're going to do some problem solving in order to help her get her bus pass again. That was a really great example. Thank you for that. Does anybody else have any other suggestions they would like to make? All right. Thank you all for that. That was great. Those were good examples. And thank you everybody for participating. I really appreciate that. All right, so let's keep it moving. So this is going to be our first supervisor checkpoint, and I have these throughout the training. But how do you specifically work with your staff to train them to provide intentional services? Is this an onboarding process thing, or is this something that you explain when you start doing like the shadowing process, maybe, if that's something that you do? But how do you train, or how do you discuss with your staff this idea of providing intentional services? And is there any resistance to this idea of providing intentional services? I'm going to give everybody a minute to gather their thoughts and see and think about how, as a supervisor, you do this. As you're thinking about that, another question I had was, what suggestions do you give staff when they're struggling with providing intentional services? And this specifically refers to if maybe the staff is receiving some pushback from the consumer on, not just doing check-ins or providing transportation, but actually working off of the plan. So Patricia, you said that you utilize a daily planning tool that allows the person to build their service before going to complete it. It lays out the goal and the medical necessity and interventions used. Wow, that seems like a really great and useful tool. I wish we had that out here in New Jersey. That seems really interesting. And I'm assuming it's helpful to the staff, Patricia. Bill also mentioned one of the things that helps staff understand that providing intentional services is important is to educate them about the payer will not pay for services that are not intentional. And that's tough, right? I think that was very tough when New Jersey was transitioning from like regular supportive housing to fee for service, for staff to kind of transition to this, well, the state's paying us to do this stuff, but now Medicaid is not going to pay us to do this. And there were a lot of staff that pushed back, like, well, we're not just here for money. Why does it have to be about money? But unfortunately it does, right? Because agencies, organizations, you all have to stay afloat, right? And in order to do that, you have to provide services that your payer is actually going to pay for. So that's a great point, Bill. Staff seem to have some pushback, but once they get the hang of the tool, it helps not only to give intentional services, but helps write their note at the end. And that's key, right? Because as we know, every time we go out and meet with somebody, every time we have a call with somebody, we have to document it, right? So if there's something that is going to help with documentation, I'm all for that, Patricia. That's awesome. That's good to know. Okay. Any other feedback from supervisors on how you train your staff to provide intentional services, and what suggestions you have for staff if they're struggling with providing intentional services? Do you supervisors out there, do you not have any staff that struggle with this? Because I'd also be interested to hear about that. Oh, awesome, Amity. You guys have weekly team meetings on Mondays and talk about any issues and help them plan interventions for the week. That's great. So it seems a little bit of team meeting kind of clinical supervision. Yeah, it's helpful when it's a small team. I had a pretty small team also. At one point there was just me and 2 staff. So it was good to just kind of sit and speak about all of the individuals we were working with and kind of plan things out and talk things out. So that's awesome. All right, cool. Those are some great suggestions, everybody. Thank you all for participating. If you guys have anything else you want to, oh, I have Megan here. Some of the struggles are confidence in their abilities, especially newer staff to the field. So encouraging them and providing the support to figure it out together. That's a really valid point, Megan. Because when you have, what is it called? Like imposter syndrome, right? Especially with staff that are newer to the field, they just got their degree, they have a job, now they actually have to do these things. It's almost like you feel like, oh my gosh, I'm not good at this, I can't do this, right? So that's a great point, and not something that came up with anybody else. That, yeah, definitely confidence in your abilities and encouraging the person and making sure that they know that even if they're having trouble, you as the supervisor are there to support them and work it out with them. That's awesome. That's a really great point. And that's part of supervision, right? You have to support your staff and be their cheerleader. Awesome. All right, so that was all I really had for intentional services. Just to kind of give everybody an idea. Oh, we have something from Lance. So one thing that I'm currently struggling with is when the peers I meet with not wanting to engage, or in a new case, the peer is almost completely nonverbal. So when writing my notes, it's difficult to show what I worked with them on and just attempting to show what I did. So Lance is struggling because some of the individuals that you're meeting with, Lance, either don't want to engage or are potentially new to the program. So they just don't want to talk to you, right? They just don't want to say anything. So when writing my notes, it's difficult to show what I worked with them on and just attempting to show what I did. So we're actually going to get into documentation. If nothing was really accomplished, is it still billable? So I would say no, Lance. I would also say definitely speak to your supervisor or whoever is in your utilization and compliance office. But the general rule out here is if you can't document accordingly the service that you provided and put enough information in the note to justify the time that you spent with them and to really justify what you did, it's probably most likely not a billable service. But you do want to document, even if it's not billable, the fact that the person is, either refusing services or is, I don't really like the word resistant, but is sort of resistant to receiving services. And that's why they're not making progress, right? So they have a plan, they're just not willing to work on it, right? And I think something to think about is if they have a plan and they're not willing to work on it, is it their goal? Like, is the goal that's on the plan something that they actually want to work on, right? That might be something to think about. But if anybody else has any suggestions for Lance, please feel free to type them in the chat box, because that's a tough situation. Going back to this idea of the golden thread though, and Lance, some of the stuff we might talk about in returns to documentation might be helpful, but if not, we can definitely come back to this toward like when we have more time for discussion, okay? I don't want you to think I'm ignoring you, okay? But after this idea of providing intentional services, this last piece you're going to do is document the services and ensure that the services tie back to the plan, and then ensure that they tie back to the assessment, right? And that's where this golden thread is really completed, right? Because you're looking at the assessment, the service plan, and the progress note, and ensuring that there's a link between all three of these, okay? So documenting progress, okay? A progress note is absolutely needed for each encounter. Why? Because if you didn't document it, it didn't happen, right? So even if the person doesn't show up for the meeting, you should still document it. Even if the person, even if you go there and you don't actually see them because they didn't answer the door, you should still document it, right? It's needed for each and every encounter. In addition, the emphasis should be on progress made or not made. And back to what you were talking about, Lance, you can document whether or not the person is engaging in services and why potentially they're not engaging in services, right? Because it is important for the funder to also see what's happening, what barriers are happening, and what can you do as the staff person to address those barriers, right? The note should also describe the interventions provided and the outcome, right? So you want to make sure that you're talking about the fact that you went to meet with them to, you know, identify preferences or barriers related to their goal, whether that be, you know, their goal of losing weight. So what methods they want to use to lose weight, what their barriers are to lose weight, or whatever related to the goal that they're working on, right? And then it should also have adequate content dependent on the services provided. So if you meet with somebody for 3 hours, you probably want to have more than 3 sentences, right? You want to make sure that the amount of content within your progress note reflects the amount of time that you met with the person, okay? So does anybody have any questions about these 4 points, just about general aspects of documenting progress? Any questions, any comments, anything? Okay, we'll keep it moving. So these are the required elements of a progress note. And this was taken from the Washington Healthcare Authority provider manual. I forget the name. It's in my references here. But this was taken directly from that, okay? However, I will say each agency has their own way of structuring their note. This came up a lot when I did this on Tuesday, and that's okay. Every agency has their own method. You always want to make sure that you go by whatever your agency's policies are, and that when you're training staff, that's what you're doing. But this is just sort of what HCA, some of the information HCA gave us, right? So you want to make sure that the goal addressed during the visit from the ISP is in the progress note, as well as the intervention or interventions provided. You want to make sure that the location, the duration of services are also included, and most importantly, the person's response to the intervention, right? It's very important for you to add their response, because this is where a lot of the information around what's happening with the person is going to go, okay? And then finally, whatever plan or follow-up activity is going to happen, and then always make sure that the signature of the provider and the title and the credentials are there, okay? So we have another supervisor checkpoint. So all of you supervisors out there, how do you train staff to document services, and what format do you use to document services? Is it DAP? Is it JARP? Is it SOAP? There's, I feel like there's like a DTAP, but I don't think that's actually a progress note format. I think that's like one of the immunizations you get. So Patricia, you use GMIRP. What exactly is that? I'm assuming the G is a goal. Oh, you use goal, Mason. Yes, thank you, Megan. I think that is a vaccine, right? There's another F. It's a weird day, Megan. But yes, DAP. Okay, DAP. What does, all right, so for Patricia, GMIRP, okay, goal, medical necessity, intervention, response plan. I like that. That's really interesting. Mason, what does goal actually stand for? I know what DAP stands for, and DAP is actually what we're going to be talking about a little bit. But I like that goal, medical necessity, intervention, response plan. Oh, that's okay, Mason. So you also use the goal, medical necessity, intervention, response plan. Does anybody else out there actually use this GMIRP format also? I want to write that down. That's really interesting. I've never heard of that before, and that actually also did not come up when we were talking about this on Tuesday. So that's pretty cool. I also don't have a pen that works apparently, so LIRP. Awesome. All right, cool. So how do you train your staff to use these different formats? Like, does your agency have like a formal progress note training that all staff have to go to before they start writing progress notes? At the various agencies I worked with, usually the supervisor would sit down one-on-one with the individual and just show them examples of notes and then work with them while they were writing notes, or the individual would write the notes and then the supervisor would sit down with them afterwards and provide them feedback. What kind of process do you all use? Oh, wow. So Lindsay, your agency does formal training and supervisors audit every note. Wow. I'm assuming that's a lot of progress notes, Lindsay. That sounds like a lot. Wow. It's a lot. I'm sure. Amity, yes, we have formal training and make new staff shadow and then write practice case notes. Not allowed to have their own until approved. Interesting. Right, it does get easier once they're trained, right? Because then you can kind of trust them and you know that they're writing the notes, so you're not actually reading through it as in depth, right? You're just kind of skimming it. At least that's what I used to do. Mason, you guys are currently creating a training for your peers and new hires. Oh, we also had a documentation training from corporate, but it just provided basics. Okay. Amity, you audit all FCS case notes. Lots of I need more in this case note. That's really great feedback, right? Because if you as sort of, for lack of a better word, an outsider are reading the note and you don't know what's happening, chances are if Medicaid's coming out and auditing, they're not really going to know what's happening either. So that's great. Bill, you all have a designated trainer for new staff, and the supervisors also do trainings. As you are coordinator, you also augment the supervisor's training. Awesome. Noemi, first new employee observes other counselors along with formal training about 2 weeks, and then manager reviews new employees' notes for about a month. Okay. So it seems like you all have some similarities between the way that you all supervise and train in terms of documentation, but also some differences. And if you haven't read through the chat box, I would also encourage you to, just because you might be able to bring back some interesting information to your agency and maybe change your process or strengthen the process that you guys already have. So awesome. But I mean, I think at the very minimum, you want to make sure staff are able to write notes, and it is a learning process. You know, I had staff who were working for like 2-3 years and they were still writing way too much. Shelly and I are actually doing documentation for another training project. It's a peer program that Rutgers has. And, you know, when the peer program started, there was not a lot of structure in regards to documentation, and now they're trying to implement some structure, and it's been a little challenging for the individuals in the program. But that repetition and that constant note writing is what's going to help you to develop that skill of being able to write a progress note. So awesome. Great feedback. Thank you all. All right. So I really like this goal, medical necessity, intervention response plan. And I wish I was training on this. However, I'm not. Because over here in New Jersey and what we train on in Rutgers is the DAP format. But I have a feeling that the GMIRP is probably somewhat similar to the components that are in the DAP format, right? Because the DAP format really focuses on data, it focuses on assessment, and then it focuses on planning, right? So in data, right, in the data section, you want to specify the service or intervention that was provided, okay? You want to ensure that there's a clear connection to the goal and objectives on the plan. And then you want to include who was there, where the service was provided, and the amount of time spent, right? So just all the general information that happened during the outreach, right? And always make sure that in this section, you're writing out exactly what you did, right? The service or the intervention that you provided, because that's how you're going to get paid, right? And then you have the assessment, which is the consumer's response to the intervention or outcome. The assessment of progress towards ISP goals and objectives, or in some cases, lack of progress and why that's happening. And then the assessment of change in consumer behavior. And the way that we always train individuals is and again, this might be different at your agency, but if there isn't a change in the behavior, we usually don't encourage people to necessarily document that because there's no change. But if you do show up to meet with somebody and there is a huge change, you definitely want to document it, right? And then finally, the plan, which is just the staff and consumer next steps, the follow-up or the plan for the date and time of the next service delivery, and that's the plan, right? That's it. That's all you want to do. It's the easiest part, and it's always been my favorite part of the progress note, right? So that's it, right? That's really what makes up the DAP format. Here we have a sort of progress note format, which is very similar, I think, to this idea of the goal, medical necessity, intervention, response, and plan. Is this sort of those who do the GMIRP? Is this kind of a similar format to what you all follow? So you have like the goal and then the medical necessity piece, then the intervention, and then the response, and then the plan. Is that kind of what it looks like? Yes. All right. Awesome. So I'm not surprised about that, only because this format was actually taken from the documentation that Washington Healthcare Authority actually gave us. And that's sort of how why I formatted it in this way. I will say, though, that in terms of formatting your progress note like this, the goal, which should correspond directly with what was on the treatment plan or the service plan. So here I would just copy and paste the goal. The intervention, again, just copy and paste the intervention from the plan. The location is wherever the person is. And then the response is really everything that happened in the outreach, right? So it's about what interventions you provided more specifically, if there was any other interventions you provided. So for instance, if you have a more like task-oriented intervention, like filling out a job application or filling out a apartment application, you might be doing other stuff along with that, like using motivational interviewing skills. You might be using different engagement skills, right? So that would all go in here as well. How do you all format your notes out in Washington at your organizations? Is it something similar to this? Thank you, Zakia. We do have the AmeriGroup Provider Manual. Thank you for submitting that link, Zakia. Very helpful. That's for your use. We wanted to make sure you guys had access to this. And then additionally, I'm going to talk a little bit more about this later on in the training. But how do you all actually format your notes? Is it something similar to this, or do any organizations out there do something differently? Okay, so you guys use the GMIRP. Okay, Patricia, you guys also include symptoms as well as risk factors. Okay. Now, would that go in the, thank you, Rita. Would the symptoms, what piece of the note would that go in? Do you have a separate section in your progress note for that, or do you have medical necessity? Okay, that makes sense. That makes sense. Okay, interesting. All right. So in regards to applying the DAP format to this, the data section would really involve the goal, the intervention, the location, and then the assessment and the plan piece would really go here, right? So the data is really just focusing on what exactly it is you did, how it's linking back to the goal, and then where things are taking place. But the response to the intervention is really the bulk of the note, right? So I'm going to give you all a scenario, okay? So Elaine is a 25-year-old female who has been diagnosed with anxiety and depression since high school, okay? So Elaine has lived with her parents, who she's close with her whole life, but after discussing their living situation together, Elaine decided that she wanted to try living on her own. So she states she's ready and looking forward to her new independence, but also finds the process daunting, and her symptoms of her depression have increased due to stress, okay? So this is just a sample ISP I came up with for Elaine, right? So in the next 3 months, you're going to find an apartment within walking distance of my parents' home while learning ways to manage symptoms of my depression and anxiety. The barriers that Elaine has difficulty coping with stress, which is causing a lack of motivation related to the moving process and completing tasks in a timely manner. The objectives is within 2 months, Elaine will create a list of available housing units as well as a simple step-by-step instruction guide for herself of what information she needs to gather to fill out housing applications. Staff's going to meet with Elaine on a daily basis to assist her with reviewing available housing options in the community that meet her identified preferences and to compile a list of information and documents required by housing applications. And then Elaine's going to attend a bi-weekly education and training session for 30 minutes given by staff on the role, rights, and responsibilities of the tenant and landlord. And then finally, staff's going to meet with Elaine 4 times for 60 minutes to identify her preferences and barriers related to successful tenancy, including collecting information on and identifying housing retention barriers, right? So from here, I created an example progress note, okay? So as you'll see, the goal is to find an apartment within walking distance. This is taken directly from the ISP. The intervention, which is for staff to meet with Elaine in person for 45 minutes to assist her with reviewing available housing options. We have the community, and then we have the response to the intervention. So I want to ask everybody to take a minute or two to read the response to the intervention and just kind of think of this note as a whole. And think about whether or not this is something that you could potentially use as a supervisor when you're training staff. And if there's anything you can improve upon to this note, if there's anything that you might add, and just thinking about whether or not this is something you could use as a learning tool, because that's sort of what I was hoping this would be for you all. I'm sure you all have come up with wonderful examples of on your own, but I always find that giving a good example of a progress note can sometimes be helpful to individuals. So think about whether or not this is something you could potentially use, and whether or not this meets the standard that you're looking for as a supervisor when you're reviewing progress notes for your staff. So I'm just going to give everybody a minute to do that. Oops. All right, so Bill. Okay, so let's start with Bill, just because Bill wrote in first, right? So Bill, you said, I may have missed it in this note, but we want to see what type of modalities the clinician used in the session. So when you say modalities, are you referring to like MI skills? Can you be a little bit more specific, Bill? And then Rita said, my concern is this note doesn't mention medical necessity. Right, so in regards to the GMIRP format, this definitely doesn't have that. So how would you, just from like the scenario, or how would you add in medical necessity into this note, Rita? Okay, so MI, CBT skills building, psychoeducation, okay. So my question for you, Bill, is, and this kind of came up on Tuesday, but what if the staff person isn't using MI, CBT, skills building, or psychoeducation? Like, what if it is just very specific about, or where could you see skills being added into this note? Because if the staff person is doing something more concrete, like in this case, finding available housing units, what if you're not using those skills? Okay. Oh, okay. So Rita, you'd add another section for medical necessity, but Mason, that helps me. So medical necessity makes mention of symptoms and what would happen if the intervention did not take place. Can you guys give me an example of what that would look like? And I really appreciate this, because I think if we were to train on this again, this might be something potentially to explore, especially if a lot of agencies are using this format of the GMIRP and adding this medical necessity in, and we want to make sure that, you know, we're training in a positive way that's going to be helpful to you all. So thank you all for this information. Does anybody have any other feedback for the note? Is this something, do you all do something similar to this in terms of sharing like a good note with your supervisees or with the staff? All right, well, we'll give everybody a chance to gather your thoughts. We'll move on a little bit. So just some things to further consider. So if we go back to the chat, so something like client is experiencing suicide ideation, difficult getting out of bed without intervention, client will continue to decline. Oh, okay. All right. So I'm sort of amazed here, I think, because this is definitely very different. This format is just very different than what we train on out here in New Jersey. So it's very interesting that this is some of the information that you might include in this format. So saying client is experiencing suicidal ideation and difficulty getting out of bed. Without intervention, client will continue to decline. Depression will increase and suicidal ideation will become suicidal plans, which will result in readmission into inpatient. It's very interesting. And thank you, Bill. So an example of psychoeducation and skill building regarding this note would be this clinician educated the individual on coping skills that could be used and then demonstrated a few of the coping skills. Also had the individual try a few of the coping skills that will assist with reducing their symptoms of depression and anxiety related to housing. Great. And you know what, Bill, this might even be, and I'm happy that we talked about this feedback here because I'm a firm believer that progress notes can always be improved. Always. You can always include more information. You can always make things more succinct. You can always make things more clear. So even if you think you have enough information, you might need a little bit more. And I think it was you, Emily, who answered or who said that a little earlier in the chat, that you can always include more information, right? So thank you, Bill. And Elke, you said goals are in the service plan notes, never thought about placing it in the progress notes. So Elke, what's the difference between a service plan note and a progress note, if you don't mind me asking? Because the reason why I'm asking is because if Medicaid is not reviewing like the service plan notes, or if like, you always want to make sure there's that golden thread, right? So even when you're documenting services, you always want to make sure that there's that linkage back to the goal, because that's how you have that linkage back to the service plan. So, but you always want to do what your agency is, what their policy is, what their suggestion is, but it is something to think about. So just some further considerations, right? So providers, as a provider, you are liable for errors, even if they're unintentional. And I'm sure you all out there who review progress notes, you guys see that there are errors in notes sometimes, right? So something that we always want to acknowledge is that you want to make sure that when you're reviewing the notes, which I'm sure all of you are doing, that you're reviewing the time and date of service for errors, right? And that you're ensuring that the service date, service type, duration, staff information, and location are included. You're ensuring that the intervention reflects the appropriately identified goal, and that errors can open agencies up to increased scrutiny and more oversight and overpayment. So something that actually came up on Tuesday with the direct care staff that I mentioned is, when I was working in the field, there were plenty of times where I would write a progress note and I would say I met with a person from 1 p.m. to 2 a.m. or from like 11 a.m. to 11 p.m. I was meeting with them for way longer than I was. Is that something that you all see in your progress notes? Because a lot of the direct care staff on Tuesday said that that's a mistake that they make sometimes. So I'm wondering if you all are seeing it on your end. And one thing to think about is, even though errors are unintentional, it's still something to be mindful of. And it's directly related to this last point that I make, is that errors can open agencies up to increased scrutiny, more oversight, and a repayment. Because if an auditor is seeing an error consistently, they could potentially use that as a way to say, well, 5 out of 6 of your charts had this error. We need to look at more charts to see if this error is happening across the board. Oh, that's a great point, Bill, to make sure that the location is consistent. So making sure that the location, if you're saying it at school, it's matching what's happening in the narrative, which might say at home. And then your contracts require exact time reporting, so you have that down. That's interesting. A lot of the participants on Tuesday were talking about like their EHR having like a stop in the system to make sure that that didn't happen. That's something that I had in my agency, had to have. But just these that might and it sort of depends on the lens that you're coming from with this. Because if you as a supervisor are seeing things very differently than your staff, right? Because you have to worry about budgets and you have to worry about payers and making sure that your program is making enough money and is sticking to the budget, that you guys are in the black, that you're not in the red. Whereas, to a staff person, having the location not be consistent or, having the wrong time, right? Because again, another thing with inconsistency, Bill, might be if you're documenting that the duration of the outreach was like 45 minutes, but in the narrative of the note, you're saying that you met with them for 30 minutes, right? That could potentially cause a discrepancy, right? Because how much time did you actually meet with the person? What did you actually get paid for? Did you get paid for the full 45 minutes? Did you get paid for the 30 minutes? What was it supposed to be? And that might not seem as big of a deal to some of your staff, just because they're just not aware of how that could potentially affect the agency if an audit were to happen, right? And you're absolutely right, Elke. There's always room for improvement. Something that I always suggest is to make sure that you have enough time to sit down and write progress notes. I would have staff, I'm not sure if you all as supervisors experience something similar, but I would have staff that would take their documentation home. I would see what time they were signing off on their notes. People are signing off on notes at 11 o'clock at night, 12 o'clock at night, 1 o'clock in the morning, because they're just, they have so much free time on their hands during the day that they have all this time to write progress notes. And it's tough because I think that also could potentially be a factor, right? If you're writing a progress note late at night at home, are you writing the note as well as you could be if you were, in work, present at your office, the information fresh in your mind, right? So that's also something that I would always train my staff on, is really encouraging them to have time at the end of the day or in the morning when they came in the next day to be able to sit down and do their documentation. So just another staff check point here. How do you all monitor your staff progress notes? I know some of you said that you audit them. You guys have to read every note. Do all of you have to read every note? Is it just like a percentage of notes? And if you're monitoring them, is there a specific tool that you're using? Okay, so Patricia, you seem like you have a really cool electronic health record. So you monitor each note for the supervisees assigned to you, and then your program allows you to view and then accept or reject with why you're sending it back. So that's great because you're able to give the person concrete feedback. about why the note isn't where you want it to be. And Lindsay, it seems like you do something similar. So Megan, you guys do supervisor and peer reviews. Our billing company also ensures the necessary information is present for billing before proceeding with submission, along with incomplete alerts from the EHR. Wow, so Megan, your agency or organization actually has this like a billing company that's a separate entity from your organization? Wow. Bill, you guys, as you are staff, I do random audits on medical records for clinical staff twice a year unless there are problems, and then I will do more frequent audits. Interesting. So speaking of audits, so I know, Bill, that's what you do, but what about like auditing documentation as a larger concept, not just necessarily the progress notes, but what is your auditing process for charts? Is that something that as a supervisor, maybe not necessarily as like a UR staff like Bill is, but as a supervisor, how do you audit your charts? Is that your responsibility? And Megan, what kind of incomplete alerts, like what exactly does that mean? Are you saying that your EHR like keeps track of like dates for you and will let you know if something isn't in the EHR by like a specific date, or if there's information missing? And once again, thank you all for your participation. I really appreciate it. Okay. And then what specific information when you are auditing, what do you look for? Angela, you guys have many audits periodically on your clients' files. We have all of our files electronically. We use the SetWorks database. It's interesting. I'm going to look into that. SetWorks database. Okay. And that's great, Angela, that everything is electronic, right? It makes it a lot easier. When we were transitioning at my last agency before I came to work at Rutgers, it was so challenging to flip from paper to electronic, from paper to electronic. Things were still paper, some stuff was electronic. It was like a mess. Oh, cool. So that's awesome, Megan. So your EHR lets you know if required information is missing from the note, treatment plan, a signature is missing. That's great. Oh, and you guys in the back end put those instructions into the EHR. That's awesome. So Lindsay, when you're going through, so I have something for you, Lindsay, that might be helpful in terms of making sure all the DAP information is correct. All right, and that's great, Angela. You guys were able to scan everything in pretty easily. That's awesome. Okay. So it seems like your agencies do have some kind of process. And then setting alerts for when treatment plans must be updated if they aren't updating as needs are met or changed. You know, I'm really jealous of you all out there because like it was probably just the EHR that my agency specifically had, but I had to manually keep track of a lot of this stuff. I actually had an Excel spreadsheet that I kept track of, and then I updated like when I needed to kind of keep track of like dates, when things are due, when the assessment was due, when the treatment plan was due. We had like an auditing form that like my supervisor created, just to kind of keep track of a lot of this stuff manually because our EHR wasn't able to do a lot of this stuff. So that's awesome that your EHRs are capable of doing a lot of this stuff. That's really good. All right, so what I wanted to show, and Zakia put this link into the chat box a little earlier, is the supplemental provider manual for FCS. Have you all seen this before? And oh, Emily, you're trying to transfer all our Excel spreadsheet info into our encrypted database now during the COVID downtime. Oh, that's a good idea, right? There's a lot of downtime. So Megan, you've seen this. I'm assuming most of you have seen this. So what I tried to do was I tried to see if there was any specific like auditing tool that was out there for AmeriGroup. And I'm going to stop sharing for a second and share a different screen, because what I ended up finding, oops, not what I wanted to show you, was that there isn't. So if you actually go to the provider manual, thank you, Zakia, it basically says that FCS providers are responsible for establishing a continuous quality improvement program. This includes collecting and reporting on data that permits an evaluation of goal achievement on individual level, clinical outcome, experience of care outcomes, and quality of care outcomes at the population level. So I found that that was sort of interesting, that each agency basically, or each organization basically has to come up with their own way to monitor your individual programs, which I guess makes sense because you all do have different programs. But I also thought it would be really nice if there was some kind of tool. It seems like you all are pretty, at least the one, everybody who's running in the chat, I'm not sure about those of you who aren't participating, which is totally fine. But for those of you out there who may not have a system, I wanted to be able to like show you some examples, especially from what other individuals are saying, but just, I guess, some things to look for, or a good place to start. So basically FCS says it's up to providers to determine how they want to audit or manage their documentation, right? So what I basically did was I did a just general Google search of behavioral health chart audit template. And a lot of different options came up. I tried to find something from AmeriGroup, but I couldn't actually find something from AmeriGroup. So this is from United Healthcare, and this is from their behavioral health. So it talks about the initial assessment, being completed in the time frame, yes or no. I think it's very specific to their program, but I thought giving you some examples of a template, or kind of giving you an idea of where to find some of these things, might be helpful, just in case your agency is not at a point where you're, looking at auditing charts and you're looking at auditing notes. Because I was thinking more from like a supervisor standpoint. These were things that I did for my program. Again, I had a very small program. And not that I had a lot of free time, but I did make time to sort of go through the charts independently. But that was basically my role. We did have like utilization review and our compliance officer, but they weren't really going into our charts to make sure that the information was correct and up to date. It was really up to the program managers or myself as a supervisor to do that. And that was really overwhelming for me. Because it wasn't a responsibility I really ever had before. So if you just Google, there are plenty of examples out there of maybe what to look at and like what to focus on. And my suggestion would be for you, if you have Adobe and you're able to convert PDF documents to a Word document, you can download any of these documents that are PDFs and put them into a Word document, and then basically make them focus on, put whatever information you need in them. Another one that I thought was interesting that I will share with you is, this is from Magellan Healthcare. And this is just their treatment record review tool, which just, again, has some general information. It's 2 pages. It's relatively short. But I like that it has all of this other information in here that I'm not sure if you guys focus on, but it's something that we have to focus on in New Jersey. So ensuring that, the Bill of Rights is signed, or if it was refused, any advance directives, the consent for medications or consent for treatment, that all of this was signed, because this is something that New Jersey puts a somewhat large focus on. So that's also something that might be helpful. And I'm not gonna, this is just Magellan Healthcare, their treatment record review tool, if you guys wanted to just Google it. But my suggestion would definitely be to just, if you're out there and you don't have the sort of process for auditing your charts, come up with something on your own, or use one of these templates. So it seems like everybody here has a pretty good understanding of that, of auditing though, right? Is that the kind of general sense I'm getting from everybody? All right, cool. So that's good to know, Amity. It sounds like you guys are trying to improve the process. And like I said, I was hoping AmeriGroup had something consistent, but I think because from what we've been told by like your FCS, like I guess Kimberly and Dawn and Amanda, I'm not sure what exactly their titles are at Washington HCA, but from what we were kind of told, you guys just have so many different programs under this FCS umbrella, you know, so you have employment, you have housing, but then in terms of housing, there are different housing authorities that provide FCS services. So that's probably why they weren't able to come up with something concrete for all programs. But definitely just doing that quick Google search and just kind of coming up with ideas, I think for me was helpful, just because I've been out of the field for so long and I'm thinking to myself, well, what even goes on an auditing form? So just doing that quick Google search was kind of helpful. And I used to use Excel, and that was a really great tool for me to use to be able to kind of come up with a form or a chart to use, okay? Any other questions about auditing and auditing tools? So if you do have questions, feel free to type them in the chat box. But the next thing I wanted to go over with everybody is the DAP checklist. And this, Lindsay, this is for you. This also might potentially be helpful. Thank you very much, Zakia. Zakia just put the link in the chat box. I'm actually going to open up the DAP checklist. Now, here's the cool thing about this DAP checklist. I know that some of you out there, or most of you really, don't use DAP, but this is a Word document. It's shareable. You guys can download it and you guys can access it. And if you all who are using the GM IRP format don't have something like this, you could definitely use this as a tool within your agency and just reformat it to follow that process. But it really breaks down what is supposed to be in this DAP progress note. And this is something that your staff can use to sort of audit and monitor their own notes, okay? Or as a supervisor, if you're monitoring notes, you can also use this. So in the data section, it basically just focuses on what is supposed to be the data and whether or not these things were addressed, what's supposed to be in the assessment section and whether or not these things were addressed, the plan, and then just general checklist information. So is the note dated and signed? Is the consumer's name on the note spelled correctly or within the body of the text? Is the note strengths focused? Would someone not familiar with this person be able to read this note and understand exactly what has occurred during service delivery, right? So these are all things that absolutely 100% should be in every note. So this is something that you all could potentially provide to your staff as a way for them to self-monitor and for you to self-monitor. But the other reason why I really like this checklist for staff is because it is a Word document, they can type right in the document. So is it linked to a goal from the rehabilitation plan? Staff could actually say, you know, writer met with Elaine in order to work on her goal of finding an apartment near her parents' house in the next 3 months. And then so on and so forth. Go down the list to make sure all of these questions are being answered. So, you know, writer followed up with homework from last visit, which focused on Elaine's progress with learning a new coping skill to help manage stress, right? So what do you all think? Do you think that this is something that could potentially be helpful? Would you use it? Would you not use it? What are you all thinking out there? So Kate, I will, when I send this over to, so if you go through the chat, Kate, and you should be able to download the chat once the webinar, the meeting ends. These links are all shareable. So if you click on it and download it right now, you can download it and this is yours. But what I'll do is I'll make sure that this, as well as the AmeriGroup manual, is sent with the PowerPoint when the HCA, when Kimberly sends out the PowerPoint with the link to the recording. I'll make sure that this is sent out as well. So good, that's awesome. I'm happy to see that this is something that could be adapted. How about anybody else out there? Is this something that might be helpful? Or do your agencies already have something like this for staff to help them self-monitor notes? Yep, no, absolutely, Kate. We can definitely send over the links. Mm-hmm. Yeah, I think that's why we sort of promote this tool, Megan, because it can be constantly used. I mean, you can use it on your computer. You can print it out when, back in the day when we were in an office and we were working out in the fields. You can print it out, you can leave it on your desk, you can put it on your wall in front of your computer, or you can just have it in your computer and just kind of type in it. And we've gotten some pretty good feedback out in New Jersey from people in regards to using this tool. And I think I think the best thing about it is it can be reformatted, because you all out there in Washington have different formats for progress note writing that you all use. And I wanted to be able to give you guys something that you could potentially make your own and utilize in a way that's going to be the most helpful for your staff. So awesome. All right, cool. And once again, I will make sure that this document is sent out once we get to, once the presentation is over. Okay. So that's basically all I had. And I know we're ending super early here, but I will give you all this time to ask any other questions, any other comments. This is the evaluation. If you guys wanted to take a short evaluation, the link, I think Zakia is going to be putting that in the chat box in a minute. But I really want to be able to answer any other questions, or if there's any other dialogue you all wanted to have. Lance, I'm not sure if you're still here, Lance. You might be. But I know you had asked that question earlier, so we could definitely go back to that if you wanted to. But does anybody have any other questions or comments or any concerns that you all have at your agencies around documentation? You know what, Zakia? I don't think I sent you the link. It's okay. That wasn't my fault. There you go. So any other questions, comments, concerns, anything? You're very welcome, Lindsay. Sorry, Zakia. Sorry. You're very welcome, Angela. So I tried to make this training very much more supervisor focused and more focused on any tools and resources that you all could utilize. I hope that I was successful in that. But again, I like this idea of you all being able to kind of chat with each other and communicate with each other. So please, if you have any questions or comments that you want to, send out to your fellow Washington behavioral healthcare providers out there, I definitely suggest you do it. Yeah. Any questions, comments, concerns? Oh. We try to make the trainings interactive, Bill, because if not, it's going to be a very boring 2 hours. So I'm happy that you found it interactive. But Shelly and I and Zakia, we know supportive housing and Medicaid fee-for-service out here in New Jersey, but you all are the experts in Washington, not us. So we can kind of teach on and train on some of these topics, but you all really know how to apply this stuff to your programs and what your individual program needs are. So we definitely have to make it interactive. We have to make sure that it's applicable and information that's going to be useful to you all. So thank you very much for the feedback, Bill. So I'm just to let you all know, I'm gonna, there's still like another 15 minutes left technically. So I'm gonna stay on for any other questions, comments. You all don't have to. I would ask if you can, please take the evaluation, as that would be very helpful to know. We're always open to feedback. But if there's any other questions, please feel free to ask them.